Okay, so here we go. The next section we are on. Let's see if I can fix that. We are on the elbow. So the key point landmarks of the elbow. Sorry, I just gotta fix something. Key parts of the elbow are right here with that olecranon. Like if you bend your elbow like at 90 degrees. Sorry for me to work this camera thing. The part that sticks right out. The part that sticks right out right here is the olecranon. And then to the sides of it, so the olecranon's in the middle, and to the sides of it are the condyles. The lateral and the medial epicondyle. The lateral's on the outside of your elbow. The medial is towards your body, towards the middle, the inside. These are key bony landmarks because a lot of your muscles attach here for the wrist. Okay, so the condyles and the olecranon, and then we have the ulna and the radius coming down. You need to get those down. Quick, easy way to think about that. The radius bone, so thumb side, that's the radius bone, and then the ulna bone is on the pinky side. Radius, thumb side, ulna, pinky side. We just talked about the spinning and the rolling. That ulna and radius to spin around wickedly back and forth when you do pronation, supination, open a door, throw a baseball, all these functional right, you do it to a degree of, all these amazing functional things that you need to do. Again, it's kind of vulnerable, that spinning and rolling. The kinematics of that wrist can get thrown off very, very easily when somebody fractures the wrist. And speaking of fracturing your wrist, I'll get into all those carpal bones. We'll get into those later. We'll definitely get into those in your cadaver class. The joint kinematics of the elbow, pretty simple really. It's a hinge joint. It's one-dimensional. Just goes one way. It does not really go much else. It always kind of sticks in that kind of linear plane. So it's not so vulnerable to injury. It's not as vulnerable as the shoulder and the hip. It's very one-dimensional kind of thing. What it does commonly do, though, is get stiff. It's a common source of stiffness and contraction. If you've ever fractured your elbow, had issues with your distal forearm or anything in there, you may have residual loss of motion in your elbow joint. Commonly, you'll see it in the clinic. Somebody has, say, fractured their shoulder, their arm is in a sling for long periods of time, stiffens right up, especially when they're older. They really need to keep working that elbow. It will stiffen up, and it'll get so stiff so quickly that you won't be able to get it back, and they'll lose motion. So the elbow joint is a hinge joint. And getting into these different motions in the anatomy, the first big obvious one is elbow flexion. Just bending your hand towards your shoulder. It's elbow flexion. Involves the biceps, brachialis, and the brachioradialis. And they all play a key role in that. The bicep is the big beauty one with the long and short head, but all of them play a big role in elbow flexion, and they can help out if, say, the bicep is damaged or detached or whatever up there. The other guys can do a lot of the load, a lot of the job functionally. Who is this? Anybody recognize her? Katniss Evergreen, I believe, from Hunger Games. She is flexing her left elbow, extending her right elbow. A lot of elbow work in archery. Hopefully you're not shooting other people with archery like she was. Okay, so let's go on with the biceps. And there's different ways of getting at these different muscles that are involved with elbow flexion. So with elbow flexion, to get the biceps, if you take your wrist fully, turn it over, palm up, and bend your elbow 90 degrees, put your hand on your palm and resist, and then a muscle test of coming up and you're pushing back, your bicep will probably pop right out. It's a good way to palpate somebody's bicep. Key spots with the bicep. See how it goes through this little groove through there. I keep forgetting the name of it. A little notch in there. Supraglenoid. No. They're intertubercular groove. Don't need to know that, but just like this little groove there in the top of your humerus. If you're looking at those bones when you're studying your bones for your exam, you might notice that little slot in there. That's where the tendon of the long head of the bicep goes. Goes way up and attaches up in here. It's key anatomically for the clinic because bicep tendonitis. Very common diagnosis is bicep tendonitis. It results in shoulder pain, usually. Kind of goes hand in hand, usually with rotator cuff issues. Anyway, this is where the source of the issue is. This is where you're getting a lot of soreness, irritation, swelling. So as a therapist, you're going right to the source of the pain, and you're doing your ultrasound, you're massaging, you're working it right in there. Also, what commonly happens is it frays, starts to come apart. Think of a string fraying, overuse, gliding back and forth over the years, and then it snaps, and the long head comes right loose. That's another topic of discussion. And this is the short head attaching to the coracoid process. So if you take your hand, find your shoulder, come towards your chest a little bit, there's a big bone that sticks out. I'll find this in the lab. That's where the long head of the bicep attaches. Whoops. There's another view of the biceps, long and short head. And there's the brachioradialis. It's kind of further down to the side. Again, a powerful muscle. With this one, if you pronate, so you come all the way over, so your back side of your hand is up, palm side is down, back side is up. Do the same thing. Bend your elbow 90 degrees and resist. The muscles that pop out are your brachialis. There's the anatomy of the brachialis. So it kind of sits behind the biceps. And the last one we have is a brachioradialis. With this one, if you stick your wrist in neutral, his wrist is in neutral, kind of like a karate chop. And then you resist that, hold it back. He's kind of, either he's very well developed or he's kind of holding himself back and doing a little isometric. This is the muscle that pops out, the brachioradialis. What do you think of it functionally? When you're drinking beer, so this young man is drinking beer, hopefully he's of age and looks like he's socially distancing. There's like people nowhere near him. So as he lifts this beer up, depending how much beer is in the cup and how strong he is, his brachioradialis will pop right out. Kind of like a beer drinking muscle. I help you remember that one. Okay, then we got the last one to tackle here, but it's also a very important one, born neglected, is the tricep for elbow extension. This thing is going crazy. For the elbow extension, this is the muscle back in here. For her, it's back in there. See how she's got her hands over her head and she's just pushing up straight to the sky. She's really working her triceps. But functionally, we have a lot of clients that are really struggling to get out of that sinking low couch or sinking chair in the living room or up off the toilet, and their triceps are weak. And you check it, you do your manual muscle testing, and she says, I'm having a really hard time getting out of my chair. What is the problem? And you now have the knowledge. You go in and say, I wonder if it's your triceps. And you manual muscle test her triceps, and she's like a 3 out of 5. And you go, oh my goodness, your triceps are weak. We need to get them strong. So you give her some exercises like this, maybe not this much weight. And you come back 4 weeks later and boom, she can get out of that chair because her triceps are stronger. So they push you up out of that chair. Great exercise to work the triceps is pushing up out of a chair, sit to stand. And there they are, the heads of the biceps, triceps, don't need to know all the heads, the medial, lateral, and the triceps, lateral heads, and the triceps itself. All those big muscles back there. And that is the end